The shuttle is launching.
Download our apps. Stream us 24/7. Find us online at kdow.biz. This is AM 1220 KDOW, Palo Alto, San Francisco.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kim McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Hi, everyone. Welcome to the show. I'm really excited about this show because when my dad was diagnosed with heart disease at the age of 78, they wanted to immediately throw him on the table and start roto-rooting his coronary arteries. And I said, whoa, wait a minute. That's one thing that you're going to go in and roto-root the arteries, but then what's next? How do we prevent his coronary arteries from continuing to build plaque? And so that's when we were referred to a functional medicine practitioner as well as a dietitian who was getting her PhD in that field. And we were able to sit back. We were able to order some advanced blood testing. We learned that he had this genetic mutation called MTHFR, which made it so that he was struggling to turn food into fuel. And because of that, this enzyme in his body was just flourishing, and it was like nails on his artery walls. And all he needed was a methylated B vitamin to solve the problem and stop the damage to the arteries, which ended up helping him with his plaque buildup and start minimizing that. On top of that, we discovered that he had a cholesterol reabsorption problem, meaning he wasn't using the restroom enough to expel all of these little troublemakers, the LDL cholesterol, versus, having a liver production problem with cholesterol. And so with all of these advanced methods of testing the blood and everything else and getting him on an exercise program, we were able to get him on track, and he's still alive today, now 5 years later, and he is doing great with just lifestyle modifications. And so I'm really excited that there is a doctor, a vascular surgeon, that is interested in metabolic health, not just starting people up and roto-rooting the arteries and creating, manual bypasses, but she is helping patients to get to the source of their problems and helping them to take their health into their own hands. So we're going to have Dr. Lily Johnston join us in just a little bit. And I know, Dr. John, this is something we talk about all the time, which is, we want to stop the revolving door of these roto-rooting procedures. And the way to do that is to help empower the patients. And that's why I'm excited about this show.
Indeed. Happy Saturday. Hello, everybody. Gosh, Kimberly, you're giving us I feel guilty now about roto-rooting every vessel I see. No, in all honesty,
we know you don't do that.
No, I know. But this is something we talk about all the time. I think I at least try to stress this to my patients. I wish that we could see patients earlier in their disease process, or at least continue to educate the younger folks in this country and throughout the world with respect to the risks associated with developing cardiovascular disease and peripheral arterial disease. Because, frankly, once they get to myself or Dr. Johnston, the horse is often out of the barn, and we're trying to just kind of keep the disease process at bay and pin it up against the wall. But we know that it will, kind of attack again, like a caged tiger, so to speak. But ideally, we want to get to these folks early, and get them on the right path with diet, exercise, appropriate lab values, and medications if possible. So this will be an interesting show because I'm really happy to ask. I got a lot of questions, honestly, so we should probably just jump right in here, I think.
I think so too. It's time for a moment of inspiration.
Dr. John Phillips' spectacular vascular moment of inspiration.
So real quick before we get to that, there's something I did want to share because when I hear that noise, it reminds me to like stand at attention. So can you indulge me for a second here, Kim?
Okay.
The Joint Commission, there's a new name to it, but it's kind of that government body that comes into hospitals and make sure that we're doing our processes are appropriate. So the cath lab at Riverside played a joke with me with one of the patients who unfortunately we've done quite a few procedures to. So in preparation, they kind of tell you that they're coming at some point. There's a window. So we were just dotting our I's and crossing our T's. And the cath lab staff said to me, well, the Joint Commission has a new policy that if there's a veteran that you're treating and the veteran would like the Pledge of Allegiance said before the case, we have to do that. We stop and say the Pledge of Allegiance. I'm like, okay, that sounds a little odd, but whatever. And so, I walk and they tell me this. And I say to my patient, he's like, yes, I'd like the Pledge of Allegiance said. Okay. So we have screens where we look at the images and you can, it's a computer, so you can throw stuff up there. So sure enough, a flag is sitting on this, 48-inch television screen. And here we're saying the Pledge of Allegiance the whole time. I'm thinking, man, this is really strange. The government, God bless them. There's certain things that I love for the veterans, maybe clean up the VA a little bit, but do we really need to say the Pledge of Allegiance? So anyway, we did it. And then I believed it, honestly. And then this was a couple weeks ago. This week, they told me it was a joke. And so they got me there. But it was just, it was
the
one
fact
of the,
that they got the patient in on it.
I know, exactly.
I'm
I mean,
surprised the patient just held a straight face.
I'm surprised too. I mean, the whole I thought it was a little bit weird because everybody had their masks on a little bit early, and I think they were just snickering at me and recording it and whatnot. So anyway, they got me. But having said that, I do have a moment of inspiration, and I wanted to find something about prevention because again, this is kind of what we're talking about. So this is a quote from Dr. Vivek Murthy, who was one of our Surgeon Generals, and it kind of talks about prevention. But he says, prevention is the foundation of public health and a critically important element of our healthcare system. But prevention is also deeply personal. It's about decisions we make each day for ourselves and our families. And that's, to me, the key. It is a very personal thing, prevention. It's kind of these atomic habits. Small changes can really have a long-lasting effect, but you've got to make them early and often, so you're not, on the cath lab table getting potentially your arteries roto-rooted.
And that's where I think it's so important to personalize it. I know you need some sort of standard, but I know for my dad, the one big thing that I think made the difference for him in compliance was the dietitian said to him, what are your non-negotiables? Starting with what are your non-negotiables, the bad habits that you just don't want to break. Then she was like, okay, so you got to have your little cocktail at night and you like sauces. So let's work from there. I'm changing everything else in your life so you can have those two things. And that really worked to make such a huge difference for him.
Understood. Because you have to, you've got to work with the patients, and it's very individualized. And you also have to understand what they're willing to do. This week, in fact, there were two folks that I was really kind of browbeating about quitting smoking, and one of them told me she wasn't a quitter, which I thought was kind of funny, but nonetheless, I mean, and you can see the husband who quit smoking is frustrated, but again, you can't force somebody to do something if they don't want to do it.
Nope. And coming up next, right here on the Heart of Innovation, we're going to bring in Dr. Lily Johnston because she might have some tips and tricks for us for helping to get patients into compliance with critical lifestyle modifications. So you don't want to miss a moment right here on the Heart of Innovation on KDOW. Don't go away.
Leg health can indicate.
I told you sometimes we
clear?
Yep.
Good.
We chatter away.
Why don't you bring us back and you can introduce Lily and her background and obviously how you guys know each other.
I can fangirl her.
Fangirl.
I've already made notes. I want to go back to Dr. Murthy and go back to early detection. Those are both great points.
Yeah, definitely. Let's, because it's just, I don't know about you, but it is extremely frustrating that as a society, we are so reactive and not proactive with our healthcare.
Well, do you want to actually bring her back and
Sure.
say, Before the break, we had a moment of inspiration, brought in Dr. Murthy. I do want to, because this is about prevention, I want to bring in Dr. Lily Johnston on that note and get her thoughts.
Sure.
And then we can kind of work backwards from there, because I was like.
So Lily, you'll notice that I'm allowed to bring and start the next segment. I'm not really allowed to take us to break because I'm not an Emmy Award-winning journalist, and Kimberly just does such a fantastic job. So please bear with me. I will do my best.
Takes a village.
It does, right?
Take a village. I actually have to moderate a session at AMP about multidisciplinary approach to treating critical limb ischemia, and it does take a village. And it's really hard to get across to these patients that it's more than just, your plumbing.
30 seconds.
Yep.
It's all sorts of stuff.
Thanks,
All right, I'll bring us back. Second segment is 9 minutes and 15 seconds.
Okay. The model of the microphone has the receiver. Yeah.
Is mine bad?
Trying. Maybe I'll tilt it this way. Is that better, Josh? Okay. Yeah, I had it pointed. I had it upside down. I'm not used to this microphone.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thank you for joining us. Just to prove that we are not amateurs, Kim, during the break, had her microphone upside down, but we're so quick on it, we flipped it upright. Hopefully you guys can hear. So yeah, let's get rolling here. So we're having a good time. Want to welcome in our guest, Lily Johnston, vascular surgeon out at Scripps. So Lily, during the break, we were kind of talking about the quotes about prevention, and you said it kind of struck a chord with you. So welcome to the show, and tell us what your thoughts are.
Thanks for having me. I am really pleased to be here with you and in a like-minded community, because I think you really hit the nail on the head talking about the missed opportunity to find these patients 10, 20 years before they end up on our procedure table. Because, of course, there is a role for the interventions that you and I both do. These patients come to us at a place where they're in crisis, their limb is threatened or their heart is threatened, and we have to do the procedure. However, my passion for this came recognizing that this is a long disease process. It takes decades for that plaque to form and accumulate and then rupture and become a huge problem. And if we could only get patients earlier in this disease process, we would have an opportunity to really dig deep into these metabolic risk factors that drive the progression of plaque buildup or atherosclerosis. And it blows my mind that we have cancer screening, mammography, colonoscopy or Cologuard testing or FIT testing. We have all kinds of screenings for lung cancer, but the number one killer of men and women in this country and across the world, heart disease, we don't have a screening test. People don't get screened. And partly this is because our interventions have not proven that useful early in the disease process. We've not done a good job, and that's on us, right? We have failed our patients in terms of really figuring out how to make meaningful change earlier in the process. But those of us who really dedicate ourselves to this space recognize that part of the problem is it's not one size fits all. The recipe for accumulating plaque is different in different patient populations. Yeah. But for those people who are very motivated, there are ways to detect disease early. And we can talk about those, but they're almost all imaging related, right? We can talk about coronary calcium score, CCTA, or coronary angiography. We can talk about CIMT, which is not super popular in the cardiology space, but is something I've used very successfully in my practice for patients who want a less invasive and less radiation-based solution. We have all kinds of options for early detection, and it's so important.
And it's interesting because you discovered this passion for, for metabolic testing, additional testing, things like that. When you were at UC Davis and you were on the amputation team, Your focus was there and you're thinking, oh my God, there has to be a better way. I mean, these patients, dear Lord, my goodness, they shouldn't get to this point.
I was in Sacramento. I won't throw UC Davis under the bus. I was not actually at UC Davis, but
okay. I thought you were UC. You were in Sacramento.
I was in Sacramento, yeah, with a separate group. But we performed all the amputations, even for patients who did not have a circulation problem, or at least a macrovascular circulation problem in vessels with names. They had a microvascular circulation problem that I cannot fix, but driven by largely diabetes.
Yep.
And it was devastating to be taking the leg off of a patient in their 40s or 50s because the infection was so rampant that it was life or limb, and the foot was non-salvageable. And then I would see them for a wound on their other foot. And it couldn't anymore, right? I know that this is preventable. We have to do better.
So Lily, let's dive into the prevention aspect of it. So if you could, well, let me ask you this. What portion of our population would you want to target right now? Like, are you talking folks in their 20s, their 30s, certain risk factors that you would identify? How would you approach this just from start to finish, if you could?
So we think of screening as the entire population, but early detection says only people at risk. So who's at risk? Let's back this up and think about the metabolic syndrome, right? So this is classically the pre-diabetes spectrum of insulin resistance. And we think of that in terms of fasting blood sugar, high density lipoprotein or HDL cholesterol, triglycerides, waist circumference, right? All of these things, and blood pressure. Those are the 5 components of the metabolic syndrome. And if you look at the United States and take the NHANES data and ask how many people in the United States meet 0 out of 5 criteria for metabolic syndrome. Their blood pressure is normal. Their waist circumference is below the standard for their gender. Their HDL is above a certain level. Their triglycerides are below a certain level, and their fasting blood sugar is normal. How many people in the American population meet 0 out of 5 criteria for metabolic syndrome? It's about 12%, or maybe even less now. So that means 88% of the population in the United States has 1 or more criteria for metabolic syndrome and is therefore metabolically unwell. And insulin resistance drives an enormous amount of the disease that you and I treat. So I would say about 88% of the population. And when do we detect this? Well, it depends on what your recipe for plaque formation is. If you have a strong family history, people in your family die in their 40s and 50s, then absolutely when you're in your teens and 20s, you need to be screened for some of these conditions because we can start changing the trajectory at that time. However, if you don't have that family history, then again, in your 30s, 40s, we just start checking. If your blood pressure is not normal, let's fix that. If your blood sugar is not normal, your waist circumference isn't normal, like these are opportunities for intervention. And the earlier we detect this, the smaller the change we have to make, right? We don't have to take an enormous detour and turn your lifestyle 90 degrees if we catch it before you end up on my table for a bypass.
It's interesting. I love that you brought up the insulin resistance. Our chief medical officer, Dr. Michael Danziger, is a diabetes reversal expert. And on a recent program, he talked about the importance of actually testing for insulin resistance as young as 10 or 11 years old, because that always seems to start earlier than when diabetes or type 2 diabetes. And with more and more young people developing type 2 diabetes earlier on, it's really critical for us to get on that wagon a lot sooner.
100%. Couldn't agree more.
So the question becomes, at least in my mind, how do we reach these folks? How do you reach a 15, 16, 20-year-old kid, their parents? And I was just thinking, they spend so much. There was an article that I just read in JAMA about unhealthy screen time, and based on the number of hours the kids are on it, it's healthy or it's moderate or whatever. But I mean, are there tools out there that we can use their social media to some degree to reach these children and raise the awareness? Because obviously they're not going to be listening to this. Well, they might be, but most of them aren't going to be listening to this. And we've got to also reach their primary care physicians too, or their pediatricians. But I mean, this clearly takes a village, and it sounds like this is something that our government should get behind. What are your thoughts on that?
I'm not an expert in the marketing piece, but I have to say that many of these patients and their families have lost hope. They have tried what they have been told to do, and it has not worked. And so they've lost trust and they've lost hope. And I think our first job as clinicians is to restore hope that these things are actually fixable, that they actually do have control and an ability to have autonomy and a say in their own health and well-being. And whether it's risk of heart disease or fatigue, they have some symptoms that we might be able to address that really is the entry door for intervention.
And coming up right here on the Heart of Innovation, we're going to have more with Dr. Lily Johnston, vascular surgeon with Scripps in San Diego, California. Also, she has her own metabolic practice that we're going to be talking more about in just a little bit. So stay with us right here on the Heart of Innovation on KDOW. Don't go away.
3 years ago, my symptoms.
Good.
Pretty good timing there, Kim. That was pretty good. I mean, you nailed it. They were going to cut us off there, I think.
I just have an issue, and I know we put a lot of pressure on our primary care, but I think that there needs to be more looked at in the education of primary care doctors. I know they have a lot on their plate, but we've got to get this stuff in there sooner rather than later. With these primary care doctors, stop brushing off even slight changes in blood counts and things like that. With my younger brother started with high blood pressure at age 16, and they just told him, oh, just stop your stress, stop drinking, your Pepsis, blah, blah, blah. Well, turns out, fast forward, he had a bicuspid valve defect and aneurysm already brewing, due to genetic, we just got some fun genetics. And I wish they would have gotten it sooner, before he was on the verge of a heart attack, because he decided to, go into bodybuilding and things like that on the side. And that exacerbated everything with his heart. And if he only would have known, he could have gotten
the primary care crisis is a huge issue, and it may be beyond the scope of our ability to fix. I think the direct primary care model is really helping, right? Those providers have more time with their patients and they do seem to be more attentive. But otherwise, I think the goal is patient empowerment and driving patients to go beyond if they're not getting the solutions and the answers they want from their primary. Now, not everybody's insurance allows them to do that, and that's very frustrating. But at some point, patients have to have this ownership of their own health to move beyond.
Yeah. And I think it starts early. I'm not sure how we're educating our kids in school about their health and how to prevent some of these illnesses, but clearly the rate of childhood obesity and prediabetes, insulin resistance is through the roof, and we need to change that. But I'd like to if we could go back when we start the next segment. It's I think 6 minutes or so is what 6+, because you said the patient you feel like they've lost hope. Did they tell you that when you see them in your metabolic clinic, or is that just something
they tell me they've tried everything, right? They'd say, I tried eating less and moving more and it didn't work, really, which is what it boils down to. And that's what most of their primaries are telling them to do, right? That's what we were taught in medical school is the solution to obesity as a disease. And if that were true, we would have solved it a long time ago. Just like if lipids were the only problem related to atherosclerosis, we would have cured heart disease 30 years ago, right?
Yep.
It's a problem, but it's not the problem.
I mean,
it's what's
inflammation
damaging the
that
arteries.
drives it. Which we don't really understand yet.
And that's what I love.
All kinds of things drive oxidative stress. Visceral adiposity drives inflammatory markers and oxidative stress. It's impressive.
You're so much fun. I love this stuff.
I'm such a nerd.
I know, but that's what's great.
Broadcasters.
But the inflammation we should get into too.
KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
We are back and better than ever. Mic's turned on, and if you're watching us on YouTube, as are our cameras, So Lily, you have a metabolic clinic in addition to being a vascular surgeon. Tell us a little bit about your metabolic clinic. Who are you who comes to see you there, and walk us through an initial consultation. What are you asking? What kind of labs are you drawing? Things like that.
Absolutely. People come see us for all kinds of reasons. Some for heart attack and stroke prevention because they're concerned about a family history that's very strong for early mortality, or they read that endurance athletes might be more likely to have coronary calcium deposits and maybe they should get that checked out. So I see patients sort of for heart and vascular issues de novo, but people also come for weight loss and management of obesity. They come for hormone concerns. They come for fatigue and just not feeling well. They come because they are newly married and want to make sure that they stay in this beautiful relationship as long as possible and stay strong and healthy for themselves and their partner. So the draw is many different things, but the medicine is actually the same. And it is, I take in my private practice, I will spend 2 hours in an initial consultation, and we go through all of the lifestyle pillars, including nutrition, movement, sleep, which is huge, stress and social connection, and toxic disruptors, including nicotine, alcohol, other substances. And then we talk about what studies patients may already come in with. Many of them are semi-biohackers and they've checked their own labs multiple times, and they bring me stacks of papers and microbiome testing and all kinds of things. And then we can talk about what else might need to be added. And then I conclude actually by doing a point of care ultrasound and taking a quick peek at everybody's carotid arteries to see if there is evidence of inflammation or any plaque that might really change how we make recommendations. And our initial lab panel covers a broad swath of things, but we do advanced lipid testing. We do metabolic testing, including fasting insulin, fasting glucose. We'll check homocysteine and uric acid, Lp(a). And I offer patients an opportunity to check their ApoE genotype because that may impact recommendations in terms of risk for Alzheimer's disease and cardiovascular disease. And we check more than that, but that's kind of the broad swath of where we go. We go in all directions. For patients who have hormone concerns, we may investigate their hormone status, depending on, labs are not so important, but vitamin D, I consider a hormone. We do check that. We should optimize that. So that's a brief encapsulation of kind of what an initial consultation would look like.
It's interesting. This has to be cash-based because a lot of insurance companies don't cover the advanced testing, which is frustrating. I had at one point an insurance carrier that refused to actually test for homocysteine, and the patient had to pay cash. And that was, I mean, even the American Heart Association, I don't think they talk about it enough, but they do mention it on their website that it's an issue. And they relate that to that MTHFR mutation that I talked about at the beginning of the show.
Yeah, the issue for homocysteine is that most of our randomized controlled trials don't show an impact in fixing homocysteine for cardiac events. The Cochrane review does note a small signal for stroke, and maybe that's a topic for another day, but I have a hypothesis about why the treatment that they used to manage homocysteine and manage methylation defects was not successful in the myriad of randomized controlled trials that were done, but I think they used the wrong agent. They did not use a methylated B. They used cyanocobalamin, which is potentially nephrotoxic in patients with renal insufficiency or kidney damage.
Interesting, because it ended up working for my dad with the methylated B vitamin. In fact, he's on Metanix, which he has found incredibly effective.
Yeah, that's what I use in my practice as well, a methylated B.
But Lily, real quick, so you spent 2 hours for initial consultation. We're lucky to get 20 minutes at least in my practice. So is this cash-based, or how do insurance companies cover this?
So far, it's been cash-based, but I'm now going to bring it into Scripps. And so we're going to see what we can do in an insurance model. And I've run the numbers, and I'm planning to do an hour for an initial visit and half an hour for follow-ups. And my plan is just to have more visits to see if I can make that work and provide about the same level of care. Now, it's not going to be the same. It just can't be. But we can bill for evaluation and management. These are covered services. Preventive care is a covered service. And I think if we are creative about how we conceptualize this, we can also bring it to an insurance-based market, but it does mean that we have to run the numbers and show that value add to our business partners in the clinics and in the healthcare space when we're part of a larger organization. But I think I have to be able to provide this service to the patients who need it most, and those are largely insurance-based patients, not cash.
100%. That's the thing, right? You have to be able to democratize this, because those that can afford it, sure, but most people that we see are those that need it but can't afford it.
The people who need me most cannot afford it on the cash side.
Nope, but you also have to make a living. So it's important for people to understand that as well, that doctors need to live. And so they need to charge for certain things. And I love that your hospital is leading by example. I love that you're fighting for that preventative care that we've all been wishing for to become standard across hospitals around the world. And coming up next, right here on the Heart of Innovation, we're going to hear more about the advanced testing that she does that you may want to request from your doctor as well. Sometimes it's the groundswell that is going to create the change that we all want to see. So stay with us right here on the Heart of Innovation on KDOW. Don't go away. You would love to talk about the advanced the inflammation and also testing for inflammation. I actually had a patient, I couldn't believe it, that came to me and with LPPLA2, and I was like, your doctor actually did that, and made such a difference that they're following to see it's the inflammation actually in the artery. And what's so frustrating to me is there's still so many doctors that are waiting for the evidence, but here you are at the forefront trying to help create the evidence. You're looking, hey, what's out there is not working. So how do we create something new? And how do we personalize it for people to create the change?
I mean, some of it just comes with trying to be humble and intellectually honest about what is and isn't supported, right? CIMT is a class 3 recommendation from the American Heart Association, meaning they do not recommend it. And yet it's a cornerstone of my practice. So, it doesn't mean it's the only tool. It's a good one. And in my hands, I believe that it's reliable, but I appreciate that is not the mainstream view, right? The mainstream view is that there's no role for supplement. I was just looking at a, preventive cardiologist's Instagram last night, and she was all on and on and on about how, supplements are just expensive pee, and there's, no deficiency that needs to be fixed. And she's so rooted in the 10 years old randomized controlled data that she can't quite get past that to extrapolate and to personalize and to wonder if there was something wrong with the studies, right? I mean, this is the next level of interpretation. It's what Peter Attia calls evidence-informed rather than evidence-based medicine, right? And understanding the limitations of our evidence-based.
It's part of the blind spots. I forget who wrote that book.
Marty McCary.
Yeah, I mean, it's the blind spots that we have, and we take things.
Hormone therapy is another great example of that, right? People, back and forth. My mom was just on the FDA panel that looked at that.
Peanuts.
She was? Yeah. That was huge.
Yeah.
They got rid of they're getting rid of the black box warning.
Well, we'll see what they'll do with that. But yeah, the panel was a big deal, and my mom was front and center on that. I'm pretty proud.
What does mom do?
She's a GYN, OB-GYN.
Okay. Yeah, it's they talk about a whole generation of folks women missed out on that therapy.
And I mean, mortality, right? Especially UTI and hip fracture related mortality as a consequence.
Yeah. So do you want to, next segment is, what did
6 minutes.
6 minutes again. How do you want to take the conversation direction? Do you want to go into some other testing that you do? Do you want to walk us through?
You guys tell me what you want to talk about. We'll go. Kim wants to talk about inflammation. We can do that.
Okay.
And the advanced lipid panel, because still there are doctors that actually tell my patients that your cholesterol is normal. And they come to me and I hear it over and over again. My cholesterol is normal. I don't know why I have this. I don't know why I have to be on a statin or take action. I'm like, well, you don't really know. That's the quantity, not the quality. And so you want to know the quality, right? And what I was told is that the particle number can indicate whether or not you have damage happening to your arteries as well. So I don't know if that's something that you can address. Am I on the right track?
We can certainly talk about it. I do think that there are many patients for whom LDL-C or the cholesterol or the cargo that is being carried by the particles is discordant from the amount of misbehaving or atherogenic particles that they have. And so that's when ApoB or particle number comes into play. Remnant particles like triglycerides and VLDLs and IDLs come into play. Things like Lp(a) may come to play, right? We have a lot more nuance now than we did 50 years ago when we started measuring lipids in the blood.
Yeah, it'd be great if we could cover just a little bit of that. And then, oh, we have Bobby Threet that's joining us. Yay. Hi, Bobby. Good to see you on YouTube. He's great. He had one of those acute situations, but he's on
Good
track.
morning, he said. He must
We
be
love
out. Is he
seeing
out
him.
west? Where's he at?
No, he's Midwest.
Oh, Midwest. Okay.
So he knows I'm in California, so he might be good morning
Gotcha.
to us. And we mentioned San Diego. So it'd be great, just advanced, panels for cholesterol. And then also just the inflammation is such a huge issue. Talk about that. And then this is actually an interesting question, Heinz.
30 seconds.
About, what is that all these diseases have to do with age? What does it really mean? Does it mean that when doctors can't find any other reason, they just fall upon age as a default and say, well, you're just old, so that's just why, versus getting to the source of what's going on?
We can bring that into.
We all have death is a task that we're charged with in life. So
I tell people life is a terminal condition.
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
welcome back, everybody. Thanks for joining us, particularly those on our YouTube channel. So Lily, help me be a better interventional cardiologist. So the majority of the people I see already have, again, plaque. I've put stents in them, etc. And now we're just trying to kind of reduce their risk for another event. So on occasion, I'll see a younger person who is interested in prevention. And oftentimes I will, I'll calculate their 10-year risk based on, their age and their blood pressure and some of their cholesterol values. I'll throw in a lipoprotein a and ApoB, maybe get a calcium score. We'll kind of mix that together, make a stew, and then I'll decide, should I put you on a little Lipitor or Crestor? How far off base am I, and what else should I be doing?
Well, I first of all don't think I could probably make you any better of an interventional cardiologist, but thanks for that compliment.
From a preventative standpoint.
Yeah, overall, I think you're on the right track. All I can say though is, if your patient is under 40, you don't have a 10-year risk. The models don't accommodate that because age is such a predominant factor in the risk calculation for major cardiac events. And if your patient is a woman, that calculation is even more off kilter because of the about 10-year protective effect we get, presumably due to estrogen. However, there's a lifetime risk. And I think the most important thing is to understand that we have an opportunity to make small changes earlier in life that by the time they're 40, 45, 50, and we now calculate a 10-year risk, what if that risk is now 15, 20%? Well, we missed the boat, right? If your risk is that high at that point, we had an opportunity earlier that we just missed because 10-year risk isn't really the goal, right? We're not trying to prevent an event in 10 years. We're trying to prevent an event ever in your life, right? We never want you to have a heart attack or a stroke. So if there's anything that's going on that we know would drive plaque formation, like high blood pressure, dyslipidemia at a significant extent, insulin resistance, toxic exposures, why wouldn't we treat those now, knowing that they will continue to accumulate risk over time? And people talk about, pack years with tobacco, right? It's a cumulative exposure over time. I think of all these other risk factors in the same way, right? How many years have you had high blood pressure or significant dyslipidemia or insulin resistance metabolic syndrome or the disease of obesity, right? All of these things contribute to formation of plaque and risk for heart attack and stroke. So why wouldn't we manage them more aggressively earlier on? Now, some of this is patient dependent. Many people would like to stay off of medications, use lifestyle modifications. That's amazing. We should absolutely encourage that. And we have to make sure we are appropriately reducing their risk. And that means following these metrics over time and possibly following imaging over time to make sure that the vascular inflammation, that the plaque is either stabilized or regressing, which we absolutely see in an aggressive preventive practice.
It's interesting. I just saw a study this week that was out that the American Heart Association's CEO was talking about on LinkedIn, that this next generation is highly addicted to ultra processed foods. And that worries me as our lives become busier, as we get into the 20s and then 30s with people having families, and then it's more of what's quick, the influencers that are online that are all reaching out to the moms, or here's your 20-minute meal, open this can and open this box and this tube. And I worry about the next generation and not having these preventative measures in place and this type of testing in place as standard protocol for all of these young people sooner rather than later. They're going to keep
sure
you busy.
Right.
I mean, I guess
sooner rather than later.
Do we think, is our health system built for something like this? I mean, I don't, you know more about it than I do, Lily, but I feel like we are, like I said before, we're reactionary, and we need to pivot as the Peter Attias of the world and things of that nature to being more preventative. But that to me is a functions on a government level, and I don't know how, they turn like an aircraft carrier kind of, but that's part of the problem, right?
It's a huge part of the problem. And many of us are just choosing to go around and do it on our own first, right? At some point, we have to demonstrate effectiveness before the policymakers will really help us drive the change at the institutional level. And to some extent, it's not clear that they want that change, right? There's more money in sick care than there is in healthcare. And we don't provide healthcare, really. We provide sick care. That said,
but our hospital systems are bursting at the seams right now.
Yeah.
I think it's time for the change.
Yeah. But again, if you look at the big studies, we've not done a great job of showing that we can reduce these risks. And many of us believe that those studies were not designed to show good outcomes, and that perhaps the interventions were not aggressive enough, or they were the wrong intervention. We can talk about that, but I understand where it comes from, and it's that the data don't at the population level necessarily support those things that I'm doing. And when I look at my personal individual patient in front of me, and I look at their scans and their changes over time, what I'm doing seems to be working. What they, the patient, are doing seems to be working.
Sounds like we need a registry for doctors like you.
I'm here for it.
Let's do it. Coming up next, right here on the Heart of Innovation, we're going to have some final thoughts from Dr. Lily Johnston. So especially on inflammation, we haven't even gotten to inflammation yet, and that's a huge risk factor for so many chronic ailments. So we'll get to that coming up next, right here on the Heart of Innovation on KDOW. Don't go away. I love that. Mike is like, yeah, this is a great talk. It's so interesting because this is what we talk about, behind the scenes in our groups, is they all want to do natural stuff. They want to take their health. They just don't know how. And
so I guess we've got four minutes left. So Lily, can you just in your mind think about like one or two things that like take home points for our patients? And so I guess if we talk about the metabolic syndrome, so blood pressure and our HDL and our waist size, and what's the other one? What's the HDL, blood pressure, waist size? I'm missing two, but our insulin. So like, what would you say if you want to tackle? You can't tackle all five of those at once. What are the top two that you would try to tackle for a patient? Is it reducing their waist? Is it getting their blood glucose under control?
Fortunately, I can argue that
All of them?
Many of them come together, right?
Come together.
If you fix waist circumference and fasting blood sugar, you may also fix HDL and triglycerides.
Yes. Okay. Because I think
Then
that's
blood pressure, right? I think blood pressure
a couple
is
of take-home
undertreated.
points would be awesome. Blood pressure is horrifically undertreated,
Yeah.
and it's a whack-a-mole game.
Yeah.
No, actually, it's a pass the buck. Like, oh, hey, your blood pressure's up a little bit. Go talk to your primary care doctor. Oh, your blood pressure's up a little bit. Go talk to your cardiologist.
Oh, but it's okay at home, is what they say, right? And you're like, well, you're checking it at home. Do you have a log for me? Well, no.
And is your cuff
Yeah.
acting? You know.
But can we touch on
I
inflammation?
know Kim wants
too?
inflammation.
Yeah,
Kim wants
and I think sleep apnea is the other one that I diagnose a lot.
Yeah, that's true too. Yeah.
Yeah,
Drives all
that's
those
hard
things.
to fix. Does everyone? I
And
think
sleep
everyone
is-
has sleep.
We don't even talk about sleep. I mean, there's a lot of data that says you need 6 hours, at least 6 hours of sleep.
Yeah.
7 to 9, my friend. 7 to
How much?
9.
7 and 9. Oh Lord. But I'm just saying, right? Like, we don't talk about sleep. People, you think it's a
No,
badge
but
of
if
honor.
you have sleep apnea and you treat it, it will cut your risk of heart attack and stroke in half. I have data. This is amazing. Reduced cardiac events. Number needed to treat is like 3. It's
Do you have to
incredible.
wear a CPAP though?
Maybe, but not necessarily. It's the most effective treatment we have, but there are now implantable stimulators and oral devices and all kinds of things. I tell people
causing this? What's causing this influx in sleep apnea? I mean, it seems like everybody has
the
it.
correlation with a diagnosis of obesity is high. But there are people with deviated septums and weird jaw anatomy. If you read the book Breath by James Nestor, he talks a lot about the fact that we don't like chew crunchy food anymore, and it's changed our facial anatomy, and that's driving weird things with our tongue and where it sits in our mouth and our inability to breathe at night. It's crazy. It's either breathe or breath. I can't remember, but James Nestor is the author. It's like an
Tape your
incredible
mouth
book.
shut? Does taping your mouth shut do anything?
It does if you can
30
breathe through your
seconds.
nose. I had to start wearing an external nasal dilator at night to be able to do that.
Do you tape your mouth shut?
Not as much anymore, but yeah, I have done it. Yes.
Really? The show's not long enough. Too many questions. Too
I
much
know.
to
I'll
talk
come
about.
back.
Go ahead.
Yes, please. Yeah.
All right, Kim, I'll
That's
give you your
awesome.
wish. We'll talk about inflammation. But I do want like 2 take-home points.
TV.
Yep.
KDOW, Palo Alto, 1220 KDOW.
We aim to please.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
So, Lily, with only 4 minutes left, it's been a fantastic conversation. And Miss Kimberly definitely wants you to touch on inflammation, which, I mean, that who knows, maybe that is the apex of all our issues. What are your thoughts?
I think inflammation is an enormous opportunity for us to get involved and try to reduce risk. We should absolutely be testing for it and trying to intervene on it when we find it. Untapped opportunity here. By all means, we should.
Yeah, getting to the source of it is so important. If you can mitigate that and reduce the inflammation, then you could reduce the plaque buildup in the arteries.
I think there's
Which
a
is
lot.
so important.
There's a lot of when we talked about the GLP-1 and the improvement in walking distance and decreased pain in our claudicants. Clearly, there must be some anti-inflammatory role there as well. So that is obviously on the forefront of a lot of our minds. But so, just Lily, 2 take-home points for our listeners. We talked about metabolic syndrome. There's 5 components to it. If you do 2 of them, we just talked about during break, reducing your waist size and maybe getting your fasting glucose levels under control, you can move the other 3. Is that would that be something that we should really focus on with our patients?
Absolutely. I wholeheartedly believe that if we target the root of insulin resistance, we can actually improve all of those markers of the metabolic syndrome, because that's how they're related. So it will improve your blood pressure and your HDL and your triglycerides, your waist circumference, and your fasting glucose. If we can really target that root cause of insulin resistance, we'll get there. And the other couple things we've talked about are inflammation, but understanding where that comes from, because we know that just treating the immune system comes with a cost, right? We have reduced cardiac events, which is great, but we've actually increased infections when all we do is suppress the immune system. So why do we have inflammation? Is it visceral adiposity or visceral fat accumulation? Is it periodontal disease? Is it untreated sleep apnea. We have all kinds of reasons that there may be inflammation, and understanding why rather than just suppressing the immune system. That's where we get the magic here.
Is there a parasite in the gut? Gut health is proving to be so important. And I just saw a study about gut health and multiple sclerosis. And there's a possible link between some parasite in the gut and that issue. And so that's really huge. We're learning more and more about that every day. I'm sure that's at the heart of your practice as well. Healthy gut.
I don't consider myself an expert in gut brain or gut heart and inflammation issues. I absolutely believe that there's a role, and I believe that the nutritional strategies I employ will reduce the chance of intestinal permeability or so-called leaky gut and decrease the amount of inflammatory reaction to our foods. And many of those things that trigger our immune system are more of the highly processed things, but some people react to even the more whole food based substances. And just understanding that is a very big part of what we can offer people. But our knowledge base there is, I think, just beginning, and it's very difficult to try and have a one size fits all approach for folks on the gut side.
I'm going to put you on the spot. Real quick, 1 minute left. Any supplements that you take that you would recommend?
That's a good question.
I treat supplements like medication. So I think that's the first thing I would say is it is a drug, right? We are using an exogenous substance to achieve a specific goal. So I supplement with vitamin D3 and K2 because my vitamin D natively was below my target range. And so I think what I take personally is not so relevant as this idea that, yes, there is a role for certain supplements for patients like Kim's dad with elevated homocysteine and an MTHFR mutation. I would employ a methylated B vitamin to try to bring that homocysteine down and reduce the risk of particularly stroke, but also, in my opinion, major adverse cardiac events. So that's how I think about supplementation. It has a role in my practice, but it's very targeted, and quality of the supplements, how it's manufactured, third-party testing makes a huge, huge difference. And I cannot emphasize that part enough. Treat it like a drug, get it from someplace that makes it and treats it like a drug.
Combined, known as peripheral artery disease.
And that's a wrap.
That's awesome. So we're still live on the thing. I know Dr. John has to run, but
I got to get a haircut, guys. I'm sorry, but
so good to meet you, John.
That's since that. Lily, nice meeting you. We'll be in touch. Kimberly, thank you. Take care, everybody. Cheers.
Cheers.
Since we planned on some extra time, with you as well, we do have a few live studio audience questions that are coming in. So welcome to those of you who are still with us on the Heart of Innovation. Welcome to the after show for the Heart of Innovation. We have Dr. Lily Johnston that is here with us, an amazing vascular surgeon. She is literally my idol. She is incredible because she focuses not just on roto-rooting the plumbing, but she focuses on getting to the source of the clog. And I absolutely love that. I find that so important. So I know that Heinz is in our studio audience, and Heinz has had a couple of really good questions that have come in. One in terms of age and disease, and number two, in terms of plastics and all of the studies that are coming out talking about how there's plastic possibly clogging our arteries as well. So Heinz, go ahead and unmute and let's start the conversation with you.
Hello. Hi, doctor. Thanks for answering my questions. You answered a previous question for me, and I appreciate it. This question that I have relates to the many disease risk factors we have out there, like heart disease, kidney, PAD, diabetes, etc. And they include a risk factor of age. What does that really mean? And does it mean when doctors cannot find any other reason for a disease, they fall on age?
Certainly, age is a risk factor for every known disease, and the body eventually stops working, right? Life is a terminal condition. None of us are getting out of it alive. And that means that, of course, there will be some decrease in our body's ability to function optimally over time. And I do believe that all of us will develop a certain amount of plaque in our arteries over time, just like many of us will develop lesions in our breast or our prostate that are precancerous over time. The question is, are those diseases we die of, meaning they kill us, or are they diseases we die with, meaning something else ultimately takes our life, and these processes were sort of inevitable, but we controlled them to a place where they didn't cause fulminant terminal disease or illness for us. So I do believe that to a certain extent, by the time I'm 80 years old, I will also have plaque in my arteries, but I think it'll be a small amount. And I think it will not be what ultimately takes my life, I hope, if I'm doing my job right. And so to some extent, yes, age does impact our organs' ability to function, and stress in our organs builds up over time, just like any motor or other mechanical device. They don't run forever. So yeah, I do think age is a component of everything, but there are, how we develop disease is more nuanced than that. And I don't think that diabetes is inevitable. And I don't think that kidney failure, especially in your 60s or early 70s, is inevitable, right? Maybe by the time you're 90 or 100, those things might peter out. But my hope is that we address risks early enough in life that those are not the inevitable consequences of aging, right? It drives me bananas when patients come to me and say, well, I don't really walk so much anymore, and I don't really do anything besides watch TV, but that's just aging, right, doc? Like, I'm just getting older. To which I say, horse pucky, right? That's bananas. Like, we don't have to accept that. And I think when we accept that, we accept an inevitable decline into illness. But if we choose not to accept that, then we figure out, why don't you have energy anymore? What's going on? What is driving this? How can I help?
And it's interesting. It's hard. My dad ended up with hip surgery, but they waited until he was truly bone on bone and couldn't walk. And the doctor, my dad wanted to get ahead of this a year ago, and he's 82, 83 now, years old, and he was literally walking 4 miles a day up hills with a 40-year-old neighbor, and suddenly it started, going declining. And he went to the doctor and said, hey, we really need to fix this. I want to be walking 4 miles a day. I want to be doing this. And he says, when you can't walk 10 feet, you give me a call. He went to a second one, same thing. Third one, same thing. So literally a year later, he could barely even get out of bed to walk to the bathroom. And that's when they're going to treat him. Why does it have to wait that long? If there are people that are motivated, again, I like what you said, like preventative care versus sick care. I mean, I know there's a risk with surgery, but for him, he would have still literally been walking those 4 miles. He would have done the recovery. He would have walked 4 miles. Now, a year later, with him not up to speed, I now worry about his risk for a heart attack because he hasn't been getting the cardio workout that he was getting before. And in his body, his plaque grows pretty fast when he's not doing a thing.
Yeah. And I don't, I'm not a bone doctor. I can't speak for their outcomes. What I can say is certainly at the analogy I might draw would be for us when we treat plaque and narrowings in the artery, right? We have many patients, many of whom may be on this call, who have a 50% or a 60% narrowing. And we, as the interventionalists, say, not narrow enough. We need to wait. And the reason that we say that is because our studies have shown that when we stent or balloon or bypass narrowings that aren't severe yet, patients don't do well, right? We have the outcomes data for that, but that doesn't mean we don't treat you, right? We treat you with the things that we will use to stabilize your plaque or even reverse your plaque. And we absolutely have to talk about the structured exercise therapy and all of the interventions. So I'm not saying that we shouldn't treat you. I'm just saying that a stent in my hands for a modest narrowing isn't the solution. And I have my data to show that and prove that, but I don't know what the corollary would be for a patient with arthritis. And maybe they were just afraid of his age and his surgical risk. I don't know, but I sympathize with how frustrating that would be if it were my dad to watch that.
Yeah. Oh, to watch the decline and then to know his cardiovascular risk and it for someone who is a captain in the military and always motivated, go up every morning at 5 a.m. to do his walk with his 40-year-old neighbor. I mean, that was incredible. Heinz had another question about plastic. Go ahead, Heinz.
Yeah, you mentioned that during the show, parasite in gut, increasing, and what always enters my mind is plastics. What do you think about that?
There was a fascinating article from the New England Journal of Medicine, maybe a year ago now, that demonstrated the presence of microplastics in plaque in the carotid artery. So we know that it gets into the body and that it accumulates in the plaque that forms in our artery, but we don't know if it's a cause or if it's there as a bystander. The other thing, if you think about the microplastics issue more broadly, is we make a lot of assumptions about how we get it, right? You'll see people getting rid of their Tupperware and going to glass and other things, but it might be inhaled, right? There's actually a huge amount of aerosolized microplastics that comes from, I think, cars or other pollution things in the atmosphere that we cannot control. The wrappers on those dishwasher and laundry pods are all plastic. Plastic exists in many, many places, and we don't really know how we could absorb it transdermally even. I don't know. I don't think anybody knows exactly where the majority of our exposure comes from, to the extent that if you can choose a glass container instead of a plastic one and not heat your plastics, I think that's common sense, but I don't know if it reduces our risk. I really don't. So I think it's an ongoing story that we're learning more and more about. We'll have to stay tuned and see what we can learn in the next 5 to 10 years as we do more research.
But I think what we're also, one of the articles I read said at least what they claim we do know is that it's not, it might be the straw that broke the camel's back, but it's not the main culprit for these arteries being blocked. And you
Sure.
can't just sit there and blame it on the uncontrollable and use that as an excuse not to control things that you can control that can actually make a bigger difference in your health.
I would completely agree with that.
And we have Bob is, oh, no. Actually, Bob is watching on YouTube. So we want to get to him really quick. He had a bypass procedure and just a few weeks ago, and now the pain is worse than when he started. What are some of the questions that he can ask the doctor to help mitigate potential risk factors that might lead to these types of quick reblockings? And I know there are so many different reasons. I mean, you could have outflow issues that weren't addressed. You could have, it could be blood clots, smoking. If you're continuing with smoking after a procedure is done, that could lead to it. But can you just talk about some of those factors, and some of the questions that he could ask his doctor to get to the bottom of maybe why it occurred?
Yeah, I would say if you're having pain that was as bad or worse than before surgery, don't sit on that, right? Again, this is not individual medical advice, but if a patient came to me saying, "Doc, my leg hurts the same or worse," I would say, you got to go get that checked out. That's not something to wait on in case there is a problem with the bypass. Some people have pain afterwards because the foot that had no blood flow is suddenly getting a lot of blood flow, but you can't know that ahead of time. So overall, the things that we have to do to reduce the chances of new blockage or more symptoms in the future, more progression of the plaque formation and buildup, of course, right? We're going to talk about reducing nicotine exposure. We now know marijuana is also a driver of atherosclerosis and cardiac risk. And you'll notice I said nicotine, not tobacco. So it's pouches and the gum and the patches, all of it contribute. Now, as a bridge to quitting, of course, we'll take whatever tools we have, but overall, the less the better, right? Abstinence is the goal for nicotine, likely also for marijuana. We need to be exercising and driving our body to use these new pipes that we've put in and make sure that the body knows that we're going to use this, we're going to protect this. This is important to us. And then we have to stay on the antithrombotic medications like aspirin or Plavix or any of the blood thinners that the surgeon or proceduralist may have ordered for you. We have to think about the inflammation, right? All of this is inflammatory, and in the short term, inflammation is important. We have to have it for healing. Wound healing is based on inflammation, and that's good, but it has to then stop. Once the wound is healed, we don't want ongoing chronic inflammation. That's a problem. If we have sleep apnea, we need to get it treated. If we have stress or poor social connection, right? The other thing that Dr. Vivek Murthy talked about was the importance of social connection and the epidemic of loneliness. Patients with depression and stress are more likely to have heart attack and stroke and PAD. Like, this is a medical problem. Get a friend and go walking, right? That's more than the walking. That's also the companionship, the outreach, the reduction in stress hormones. All of this matters. And the good news is you can think about which thing you want to do, right? One of the brilliant parts of my practice is I can offer you a solution that's nutritionally based, right? We can focus on your nutrition or your exercise. Let's talk about structured exercise. Or let's work on your sleep hygiene and getting you tested for sleep apnea. Or let's talk about your connections and your social and your stress. Let's think about that. Or your supplements and your labs and your medications. How about that? Pick one. Okay. Pick the low hanging fruit that is easy, that feels achievable, and get a win, right? Get a checkbox in your book that says, I did this for me and I did it and I feel better. And now I can do another thing, right? We prove to ourselves that we are worth it, that these interventions are worth it. And we build our own confidence. So let's start with one thing that feels like you want to tackle it, that's easy and achievable, and do it. And check that box. And then be brave and pick another one and go from there.
And congratulations to Robert. He says that he is now 3 days without a cigarette. So that's really good. And it reminds me just that I think it's important, if you wouldn't mind, because Mike also brings up a really good point about, breathing in. There are a lot of forest fires. And I know for me, it's when there are fires, we're in fire season here in California, and I have to wear a mask because of my asthma, which works out well because I'm not breathing in that stuff that could actually also cause additional damage to my arteries, right? But can you talk about the mechanism of action and why anything that's burned? People were falsely assuming that smoking marijuana was safer than smoking a regular cigarette. But we're learning because Science Direct came out with that study that said that more and more patients, people between the ages of 18 and 27 are showing up in the ER with critical limb ischemia, plaque buildup in its advanced stage in the legs. And a lot of it they attribute to one, the processed diabetes, but also the increased use of marijuana smoking. So anything you burn, anything that it becomes toxic, and that's what's going in from your lungs all the way through your bloodstream, correct?
I will say I'm not an expert in this. All I have so far are the data that do demonstrate an increase in risk related, yes, to forest fires, right? That will show an increase in risk for those people who are exposed. And also recently, several papers have come out demonstrating adverse cardiac events related to the use of marijuana. Now, those are associational or cohort studies, right? These have not been randomized controlled trials. I cannot prove causation. So that's important to understand. However, it's not necessary for good health in life to smoke marijuana. Therefore, I would argue, if you're concerned about your risk, I would cut it out because the associations are very real and I'm concerned about that. And I would offer it as one more way to reduce risk for something that otherwise doesn't have a medical need.
Fantastic. Any other questions?
Patients. There are people who take it for pain control, and I don't want to diminish that, but and whether edible is the same as smoking, right? I'm not an expert in this. I don't know the data for that yet. So we can maybe expound on that another day. But for most people who use it recreationally, it's an easy low-hanging fruit to also reduce risk.
And I want to ask in our live studio audience, any other questions from our live studio audience or anyone on YouTube? I'll give you a second here just to bring them in, or else we're going to let Dr. Johnston enjoy the rest of her weekend. But I do have a question that comes in often, which is about the nicotine patches and the gum and whether it's important to wean off of that, or is that, is it safe to be on those long term, or it should only be as an in between? Will that cause the same type of damage to the arteries and the inflammation with those additional devices versus just smoking?
I think it's a matter of your ability to control the cravings for cigarettes without them, right? ultimately it would be best to have no nicotine whatsoever in your system. But if the price for that is going to be that you relapse and go back to smoking, I would say you're better off sticking with the low predictable dose that comes with the gum or the patches than risking going back to cigarettes altogether. But I would offer that, again, it is a drug. Nicotine is a drug that is toxic to the endothelium, and it would be better to be off of it completely if you can. But we're always going to talk about risks and benefits. And there's a very real risk that for some patients, they're not going to be able to manage the cravings for cigarettes off of those tools. And that's okay, right? We do the best we can with what we have. We meet patients where they are. And again, we always have other things we can do to manage risk and mitigate it. So in an ideal world, no, I wouldn't keep people on those indefinitely, but it's better than smoking. And we don't live in an ideal world. So I'm going to meet people where they are and go with what we have. And, we do the best we can.
I love that. I love that you say that because it is so important. It's been one of our philosophies. I know it's easy. I mean, we know you shouldn't smoke. We know you should eat better. We know you should walk, but not everyone has the same personality that has that drive. I mean, everyone has all kinds of other things going on in their lives, all kinds of, baggage. We all have baggage, that brings us to where we are. And so you need to personalize it for that person and meet them where they are to give them the best quality of life that they're willing to achieve as a partner in their care. And for everyone, it's different. And that even includes where we do consider amputation. We look at it as a failure of the system for the most part, but it is treatment. And there are patients that, that's their choice. Instead of going for another 9 months of wound care and revolving door procedures, for them, that's what they feel will get them back to the quality of life that they want right now. And so I love you saying that you're going to personalize it, meet them where they are, and guide them where they desire to be, which is the better quality of life, what it means for them.
Absolutely. 100%.
Thank you so much, Dr. Lily Johnston. We really appreciate you being here. If people want to connect with you and your practice, how can they reach you?
The best way to find me is through Vascular Health Institute, www.vascularhealthinstitute.org, or please connect with me on LinkedIn, Lily Johnston.